Before commencing, I'd like to acknowledge the traditional custodians of Australia. I pay my respects to their elders, past, present and emerging. And I'd also like to acknowledge the great pain that has occurred due to loss of their land, both pain in the past, but it's an ongoing pain. In opening this ASM, I should highlight that we have been meeting at this time of the year for just over 30 years. And the reason we've been meeting is to focus on ways to reduce the burden of respiratory infections through understanding the science of immunisation and promoting immunisation as a public health measure. And by saying we, it's been a group of 120 to 150 delegates meeting face to face, delegates from a broad range of expertise, GPs, hospital doctors, public health physicians, epidemiologists, basic scientists, pharmacists, vaccination nurses, government policy makers, industry representatives and patient advocates. And over the 30 years that we've been meeting, we've seen remarkable progress in the understanding of immunisation for respiratory infections, particularly influenza. And we've seen a remarkable uptake of influenza vaccination in our community from rates of less than 30% 30 years ago to rates close to 100% in elderly people, in immunocompromised people and in healthcare workers. This year is quite different. This year there's a new virus that we'll be primarily discussing, although the meeting will also touch on influenza and pneumococcal disease. This year the meeting is online, and as a result of that we have a significant increase in the number of delegates, where we now have over 400 delegates on this online meeting, and many of the new delegates will be nurses and other healthcare workers who will be involved in helping roll out the COVID vaccine. So with that as an introduction, I'd like to start with the first session, and it's on the epidemiology of COVID-19. And our first speaker is Professor Ben Cowling. Now, Ben is an epidemiologist. He's head of the Division of Epidemiology and Biostatistics at Hong Kong University, and is also head of the WHO Collaborating Centre in Hong Kong. And there's a remarkable sort of symmetry to Ben meeting with us tonight, because this time last year he was in Melbourne face to face, talking to us initially about influenza, but then at short notice updating us on this emerging new virus coming out of China. So Ben, you're perfectly placed to talk to us about the initial emergence and then the subsequent spread of COVID-19. Thank you very much for joining us.
Yeah, thank you, Lou. I'm very happy to join you again, because I was in Melbourne a year ago. And I did give a presentation. I'm going to show a few slides from that presentation a year ago. And then I'm going to talk about what's happened here in Hong Kong, because that's where I'm most familiar with what's been going on with COVID-19. And at the end, I'll touch on vaccines and vaccine hesitancy, which I think is going to be an issue in the coming year. So a year ago, I presented some information that I had on the novel coronavirus, as it was then called 2019 nCoV. And one of the slides I showed was this result that we published in New England Journal of Medicine. It was a very rapid analysis done together with colleagues in China CDC. At that time, we were anticipating quite a substantial and prolonged collaboration with China CDC. We had a number of follow-up projects planned, a number of analyses in progress, but this turned out to be the first and the last paper that we published together with China CDC on the novel coronavirus. In this particular analysis, we looked at the very early data from Wuhan just the first 400 or so cases, an estimated reproductive number of 2.2, incubation period of about 6 or 7 days on average, and a few other important parameters that I think were useful back then. At that time, it wasn't quite clear what was going to happen, but certainly it was very worrying given a reproductive number this high and transmission that was really taking off in Wuhan at this moment. And then, of course, with the interventions that were used in China, case numbers came down quite quickly. At the end of my talk last year, I mentioned a few unanswered questions. One of them was about severity. How many mild cases for every hospitalized case? Is it 10 to 100 to 1, 1,000 to 1? We now know is something like maybe 20 to 1, something like that. Mild cases for every severe, and maybe 200 cases to every death. Case fatality rate, infection fatality rate of maybe 0.5%, a little bit lower now maybe, and of course varying substantially by age. And a year ago, I mentioned the anecdotes about pre-symptomatic transmission from China. There was a German report in the New England Journal of Medicine that was retracted or corrected, but there was a worry about pre-symptomatic transmission. And then I also talked about modes of transmission, was large droplets. That's still controversial. I'm not going to say any more about that today. And then a lot of interest in the effectiveness of different interventions. And a lot of interventions that have been used in the past year that hadn't even been thought of a year ago. Stay-at-home orders and a lot of very stringent and strict restrictions. So as a follow-up to the work that I presented last year, we did go away and look at severity, and we published this report earlier last year in Nature Medicine, looking at the case fatality rates of infection in different age groups. And overall, the symptomatic CFR 1.4%. The infection fatality rate is lower because there are some infections that are not symptomatic. But this estimate has turned out to be reasonably accurate. I say maybe it's a little bit high because we know there are plenty of many asymptomatic infections, but reasonable early estimate of the severity profile. And this is a very concerning severity profile. We know that if COVID was allowed to spread freely here in Hong Kong or in Australia or in other countries, it could really overwhelm healthcare systems at an early stage of an epidemic when attack rates reach maybe 5% or 10% of the population. And of course, there's an entire population of susceptibles. So really could do enormous damage if it's allowed to spread freely. And that's why we spent so much trouble and effort controlling COVID and stopping it from spreading. We also did some analysis of the potential for pre-symptomatic transmission, which I mentioned a year ago was controversial. And I think it's not controversial anymore. We understand that infectiousness or contagiousness peaks around the time the symptoms begin, and people can infect others a little bit before their symptoms appear. And so the figure on this slide here shows our estimate of the infectiousness profile. Actually, there's perhaps quite a substantial fraction of infectiousness that can occur before symptom onset. And I want to add to this analysis something that I think is kind of interesting, and that's our analysis of serial intervals. So the serial interval is the time in a generation of infection. It's the time between illness onset in one person and then the illness onset in the next person in the transmission chain. So if one of my family members was infected and their symptom onset was a week ago, and then I'm infected and my symptom onset's today, that's a serial interval of 7 days. And so we looked at data in China quite carefully. And what we found is before the epidemic peak, so this is up until January the 22nd in China, serial interval was about 8 days on average. And then around the time of the peak, this is in orange, the serial interval came down to about 6 days. And then after the peak, after the end of January through to mid-February, the serial interval had shortened very substantially to just an average of 3 days. And so from one infection to another, between symptom onsets in consecutive cases, just 3 days on average is really a very short serial interval. And what it implies to us is that there's a lot of pre-symptomatic transmission going on. If somewhere like in China, if the authorities get very good at identifying symptomatic cases and isolating them and stopping symptomatic cases from transmitting infection, then all that you've got left is the pre-symptomatic transmission. And that's what we believe is changing in China from red to orange to yellow in the figure on the left of this slide, that there was less and less post-symptomatic transmission, more and more pre-symptomatic transmission. But for me, I'm a statistician. I like to analyze transmission dynamics. And one of the things I've been doing for the past year is looking at the reproductive number. And so maybe it started at 2 point something, and then it changes over time as you bring in the control measures. One of the things that we need to allow for when we estimate reproductive numbers is the serial interval distribution, or an estimate of the average time between generations of infection. And if you have this changing serial interval, as happened in China, as I think has happened in Hong Kong as well, you need to take that into account, and we haven't quite figured out how to do so. But that's an important methodological development that I need to work on, and maybe others need to work on as well. So this work was published in Science. After the initial emergence in China, we saw very rapid global spread. There's a nice video on this website, but I won't play the video of the numbers of cases increasing and increasing and increasing. And I think maybe some other speakers will show some more data on the speed of global spread, and now the enormity of the numbers of infections worldwide, numbers of deaths worldwide is phenomenal. And of course, China is one of the countries that's least affected. It was the earliest to have confirmed cases, but I think cumulatively they've only reported about 100,000 cases, and that's in a population of 1.4 billion. So they've done very, very well to stay on top of transmission. But of course, they have now one of the most susceptible populations in the world. And they are using vaccines in mainland China, but the coverage is still very, very low. So actually in the mainland, they may be one of the places that are going to take the longest to get back to normal, because they're going to have this susceptibility in their population for quite some time, until they can vaccinate 1.4 billion people. In Hong Kong, we've had surges of infections from time to time in the local media. They're called waves. I don't really agree with the terminology, but I've always been asked when I give presentations to stick to the terminology for consistency with people that invented this terminology. So this is our epidemic curve. X-axis is time from January last year up until yesterday. And so on the left, we have what's called the first wave, which wasn't really a wave. It was like a ripple in a very quiet pond with a very small number of cases. Imported cases from mainland China into Hong Kong, and then a very limited amount of local transmission. Things really kicked off in Hong Kong in March, when we had a lot of cases coming into Hong Kong, people who were infected in Europe, North America, other parts of the world, and some local transmission. About 1,000 cases, half of those were people coming into Hong Kong infected elsewhere, and about half of them were people infected in Hong Kong with local transmission. And then since then, we got numbers back down to 0 for a period of time. We had a resurgence in June and July, a third wave with 4,000 cases, got that back down again with public health measures. Never were able to persist with 0 cases, never were able to keep cases at 0 for very long. And we had a resurgence in November with 5,000 cases so far. And again, a lot of local transmission, a lot of clusters. The health authorities here talk about hoping for elimination. They look with longing at what's happened in New Zealand, I think, managing to keep at 0 cases for so long with a blip here or there. But the policies that have been put in place are actually more consistent with suppress and lift, meaning that when the numbers come down towards 0, then the government lifts all the public health measures, and then we would expect a resurgence sooner or later. We're very good at doing test and trace, maybe not quite as good as in mainland China and Singapore, where they're using a lot of technology, using closed circuit TV, mobile phone tracking, mobile phone applications, and so on. In Hong Kong, not so much of that, but we're still doing a reasonable job at putting people into government quarantine and stopping chains of transmission. But that hasn't been enough, as I'll show, hasn't been enough to limit surges in local cases. We have a ban on visitors now, and returning Hong Kong residents who come back need to do a hotel quarantine. It was initially 14 days, now is 21 days, which is really not something that people are looking forward to doing. There have been loopholes. So for example, air crew and maritime crew coming in on ships. The government's now talking about closing those loopholes. For example, they're talking about air crew, when they arrive, will need to do 14-day hotel quarantine, not 21, but 14. But I can't imagine airlines being enthusiastic to fly to Hong Kong if their pilots and cabin crew then need to stay 14 days in a hotel here before they can fly back, returning to their home country. So I don't know if that will really go ahead, but that's being discussed. And we're using moderate social distancing measures intermittently here. My group here at University of Hong Kong have been tracking the reproductive number over time. It's been up and down a lot. The public health measures have been used intermittently. So when the public health measures are relaxed, we've tended to see resurgence in transmission sooner or later, with reproductive numbers flaring up as high as 4 in our third wave and as high as 3 in our fourth wave. And that's maybe a little bit higher than in some other parts of the world. And then we've successfully got transmission under control with moderate social distancing measures that I'll list out in a future slide. The reproductive number currently, as we're getting the fourth wave under control, has come down to about 0.8, which is not as low as we've got it in previous waves. And I think fatigue has a bit to do with that. I've got some data on fatigue coming up as well. We've seen a lot of clustering of infections. And so in our second wave, this is the clusters that we observed. And so the settings of the clusters: yellow are social, blue is family, red is pink is workplace occupational clusters. And on the left is our biggest cluster, linked with a band that played in a number of bars, like one bar on a Monday evening, a different bar on a Tuesday evening, and then Wednesday, and so on. And a lot of the patrons of the bar got infected in this particular cluster. And one of the interesting things I want to show you in this figure, the squares around some of the circles are people that were in quarantine. So they'd been traced as close contacts of a confirmed case. They'd been put into government quarantine in a special holiday camp or in a hotel, and then tested at the beginning and maybe at the end, and they'd been picked up as cases. And so you can see some of the ends of this cluster, some of the terminal nodes are people in quarantine. And you can imagine if those people had not been in quarantine, maybe they'd be in the community, maybe they'd have a chance to pass infection to other people and keep transmission going. So quarantine did its job. It brought an end to that particular chain of transmission. But there's also plenty of circles where they didn't end in quarantine. So quarantine was not necessary. A lot of people just didn't seem to pass on infection. And in all of these clusters, there's just one case in the bottom right of the bar and band cluster. There's a superscript number 1. This is a husband who was in the bar or linked to the bar. He was sent to quarantine, but he'd already infected his wife, presumably pre-symptomatic transmission, and they picked up the wife as a case. So it was a case where, in this particular case, quarantining the contact of a contact could have prevented that, prevented anything from going further. But as it was, infection didn't spread from the wife anyway. So that's okay. We did some more detailed analysis of these clusters, and on the left is a serial interval distribution average of about 6 days. On the right is the interesting finding, I think, where a lot of cases in our second wave didn't transmit infection to anyone else. And some of those were people who were caught early as contacts and put in quarantine, but a lot of them were not. 70% of cases didn't transmit infection to anyone else. And at the bottom is our super spreading estimate. 19% of cases in that second wave were responsible for 80% of transmission events. We've repeated the analysis for our third wave and our fourth wave as well. And it's similar. It's about 20%, 19%, 18% of cases responsible for 80% of transmission events. So that's the super spreading phenomenon. And that's really interesting. It means if we can stop super spreading events, we can already limit transmission a lot. If there's a lot of cases who are not going to pass on infection to others anyway, if they're just not very contagious, maybe they don't have a lot of contacts, then if we just focus our efforts on stopping super spreading, we can already have a big impact on the spread of COVID. My team have been monitoring behaviors in the community in Hong Kong since the beginning. We've been doing telephone surveys. So each of the dots on this plot is a telephone survey of either 500 or 1,000 people. So weekly now for many, many weeks, looking at, in this slide, wearing masks almost universally in the community since January, before, a long time before it was adopted elsewhere in the world. Hong Kong was one of the first places to mask up, and seen other hygiene behaviors relatively consistent. I've got another slide in a moment on the social distancing behaviors. Now, in our second wave and in our third wave, very similar package of measures were effective in bringing transmission to a close. So at the top of the slide, we've got masks universally used all the way through. We've got testing and tracing being done all the way through, with isolation of all cases in hospital until they recover, quarantine of close contacts. Those two measures applied throughout were not enough to stop the surges of cases. So the orange measures, the social distancing measures, were enough. Civil servants working at home, which was followed by private businesses as well, reducing mass gatherings, so churches and cinemas and conferences, all kinds of other mass gatherings not permitted anymore. Closure of bars, nightclubs, karaoke, leisure facilities, and also restaurant measures. So those package of measures were introduced to stop the second wave effectively, and again brought back in to stop the third wave and worked. And right now they're in place and stopping the fourth wave. One of the things we've noticed, though, is response fatigue in our fourth wave. So again, these are data from our telephone surveys. Every week, 500 people or 1,000 people interviewed to ask about what they've been doing. And in this case, purple is avoiding social gatherings, red is avoiding crowded places. And we see the social distancing behaviors in the public do track risk. So when case numbers are low, people go a little bit back to normal. When case numbers come up, people start to worry and they stay at home more often. But when we compare the third wave in the middle of the slide to the fourth wave on the right, we see some evidence of fatigue. People maybe not being as careful as they used to be, not staying at home as much as they were before, not avoiding social gatherings as they were before. And I think that's contributed to the difficulty here in dealing with our fourth wave. The reproductive number has not come down as far in the fourth wave as it did in the third wave. So sometimes I think about analyzing how much impact the government measures have had, like closing the bars and asking civil servants to work from home. But I think we've also got to take into account how people react to those measures. And just because the government asks people to do things doesn't mean that they'll do it. And so this is our comparison to the third wave and the fourth wave. The third wave in red, the reproductive number when case numbers were rising was up to 2, and it came down quite substantially, 0.6 or 7. And in the fourth wave, started at a similar point, but it hasn't come down as far. And I think with the same package of government measures. So I think the response fatigue has played a role in that. Now I'm coming towards the end, but I do want us to cover a little bit on vaccination as well in a moment. In Hong Kong, we've closed schools many times in the past 10, 15 years for influenza, and schools have been closed. School grounds have been closed for most of the past year with a lot of online learning. But when case numbers came down to a low level, the government talked about reopening schools on condition that schools were very, very careful. And I've listed out some of the measures that were required on this slide. So daily temperature checks, universal masking, switching from full day to half day. So there's no lunch at school, no breakfast at school, no eating at school. And that's a way to make sure that children are wearing masks all the time that they're there. And then also spreading children out. In Hong Kong, when schools were open, there was a little bit of COVID in the community in June and then early July. We identified 15 cases in children where there could have been opportunities for transmission in school, but transmission didn't occur. And so we think that's evidence that maybe schools could have stayed open, although they've been closed for most of the past year. We think schools probably could have been open. There is some risk, it's not zero, but there's also a big benefit to children going to school and schools being open. So right now, again, schools are doing online learning. Now, I just want to talk about vaccines before I wrap up. Vaccines are our way back to a new normal in Hong Kong and everywhere else in the world, I think. We know that until we start using vaccines, we're going to have surges in transmission that we have to deal with. Otherwise, they're going to overwhelm our healthcare system. And so in Hong Kong, actually, even when we've been having days where there are 100 cases a day for a period of a week or two, already the hospitals start to come under a lot of pressure just with those cases that they want to isolate. We've constructed now a field hospital for COVID cases. That's been full up at times. So really, that's a low level of incidence. 100 cases a day is really not a lot. We could go a lot more than that with 7.5 million people here. So public health measures are essential to stop any kind of enormous surge in cases and hospitalizations. And I showed before our estimates of the reproductive number. If the reproductive number in Hong Kong can go as high as 3 or 4, that means we need to get at least 66 or 75% of the population to be immune. And that's not vaccine coverage. That's vaccine coverage times vaccine effectiveness. So if we got a vaccine that's 90% effective and we get 90% coverage, that's not 90% immunity, that's 81% immunity. So that's 0.9 times 0.9 is 0.81. So really, we've got to think about how we can get that much immunity in the population if we'd all like to go back to normal here in Hong Kong. And I think the same equation would apply in Australia. How can you get a high level of immunity so that you don't need to worry anymore about a surge in infections that could really cause a lot of trouble for the healthcare system? In Hong Kong, we've ordered vaccines from Pfizer, from Sinovac, and from AstraZeneca. We're expecting the Pfizer vaccines to come very soon, the first 1 million doses, and the rest should come in the next 6 months. Sinovac is coming soon as well, I believe. And then AstraZeneca maybe later this year. The government's still thinking and talking about a 4th manufacturer as well. So we'll have plenty of vaccines, much more than we need. We have a population of 7.5 million, and so far the orders that have been placed are enough for 1.5 times the population. Elderly and healthcare workers are going to go first, and the objective is going to be to reach herd immunity so that we can relax the ban on visitors, the quarantine on people arriving, the school closures, working at home, and all the other public health measures that are having economic impact here. However, we've been asking our telephone survey respondents about their enthusiasm for being vaccinated, and there's a little bit of hesitancy here. So most recently, below 50% of people have expressed that they are either likely, very likely, or certain to get vaccinated. And that's a concern to us here. Of course, that's just intention, and that can change after the vaccine campaign starts. But another question we asked is how people would make their decision to take the vaccine or not. And it's very interesting that the results that we got in this particular survey. So on the left is about 10% of people that said they will not get the vaccine. On the right is about 20-something% of people that said they're definitely going to get the vaccine. That's in blue. In the middle, we've got the vast majority, 2/3 of people said they're going to wait and see, basically. They're going to wait and see what happens. And our concern is maybe what we've seen in some previous vaccination campaigns where something happens like in Norway when there were the deaths in the elderly after receiving the Pfizer vaccine. Maybe something's going to happen in Hong Kong that's going to get into the news, into the media, on the front pages about some adverse event of vaccination. And that's going to cause an enormous amount of hesitancy in getting the vaccine in these 2/3 of people that are waiting to see what to do. And that's going to be a real challenge, I think, in the next 6 months. So hopefully we won't have to face that. Hopefully it's going to go smoothly. The blue 20% are going to get their vaccine, and then a lot of the green 2/3 of people are going to join in and get vaccine when it's available for them. But I'm worried. So I'm going to wrap up now. I think we've been doing pretty well in keeping infections here at low levels in the past year. We're doing serological studies in the community, in the general population, and in high-risk groups, including in healthcare workers. I have a cohort of 800 healthcare workers in Hong Kong with regular serology. And up until last month, only one of those healthcare workers had antibodies, had serologic evidence of infection. And so that's remarkable in Hong Kong that we've got, and those 800 healthcare workers, many of them had heavy exposure to cases. We're working in the intensive care units and in the isolation wards. So we've done really, really well in keeping infections here to a low level. We haven't seen a lot of infection in our community serological studies. And we think from our analyses, including infections that we may have missed by the testing and the contact tracing and so on, maybe 0.5% of our population have been infected to date, something like that. So we've done pretty well. Masks have been effective, but we've seen a lot of clusters of cases in mask-off social settings. I've done one analysis where about 70% of infections have occurred in places where masks are not worn. Bars, restaurants. There was a big cluster here recently in a ballroom dancing network. And then, of course, households, where households is the location where more transmissions occurred than any other setting. Early adoption here of face masks and test and trace have limited the spread, but we've needed these intermittent use of public health measures to keep transmission under control. And then, as I said at the end, vaccines provide the long-term solution. So that's my last slide. I will pass back to you, Lou, and I'll still be here for the Q&A a little bit later. Thank you.
Ben, thank you. Fabulous talk. And Ben will be part of a panel after the next two speakers. So the next topic is different responses to the COVID pandemic from around the world. And our presenter is Mary-Louise McLaws. And Mary-Louise is a professor of epidemiology at the University of New South Wales, has a long-standing interest and expertise and involvement in respiratory infections, and is a member of the WHO Health Emergencies Advisory Panel. Mary-Louise, thanks for your presentation.
Thank you very much. I'm fortunate to be a member of a WHO ad hoc. We've now moved from one committee to another. They move us around a bit on infection control, and there are about 8 themes, and we're very fortunate to have presentations from other themes such as epidemiology and Ben and others, and we learn a lot. And I'm not on the vaccination one, but certainly we are kept up to speed because this impacts our understanding of how we should develop infection control guidelines. So I'm just going to give you an overview of the situation, pandemic responses, and why I think we've got to the situation. Then some vaccine analysis of situations. And of course, people will want to know about the independent panel review of WHO. So let me talk to you about so far the response. As we can see, a classic wave response, and as Ben so rightly says initially, the Asia Pacific and the Western Pacific was more like a ripple rather than a wave. And then of course it was followed by Europe and America. And then of course the Southeast Asian. And of course, sadly, Europe and Americas have gone into a second wave, are continuing to have problems. And we now have over 105 million cases, nearly 3 million deaths. Just in the last little while, we've had 461,000 cases. And in the last 7 days, those cases have been largely attributed to the European and America's countries. In fact, 84% of those cases are attributed to those two WHO, regions. Oh, sorry, I flicked on. Are you seeing my slide with the global? Sorry, I should have shown you that. I don't know why you didn't get that one. So yes, here we go. Down here is very small numbers of cases. And here the, don't know if you can see my pointer on the yellow for the Americas and the green for Europe. And those two countries are not controlling their outbreaks. So onto this next slide, looking at where the case numbers per million population lie around the world. So the average is said to believe between 110,000 to 20,000 cases, which is really quite shameful, really. We should have been able to have reduced that considerably, and that's per million. If you have a look at the top of the leaderboard, apart from Czechia, you've got America, a very wealthy country, of course, Israel and Belgium, up there in the second tier, and of course, followed by Switzerland, the Netherlands, Sweden, the UK. I mean, countries that really should have been able to put in their interventions. Part of interventions are, of course, as Ben has spoken about, it's about human behavior. Of course, it's fatigue, but these European countries, I believe, and of course the European Society for Infectious Diseases Clinical Microbiology, have admitted that they thought that they were just going to get flu. It was going to be a bit like a really bad flu season, and had not learned from the China-Hong Kong experience of SARS in 2003. So when it came their turn, they were very unprepared to be able to get their communities to cooperate. And it does need a lot of cooperation. And I think that, as we can see, we're right down there, less than 10,000 cases per million population, and we're with Finland, Japan, Hong Kong, Australia, New Zealand, Taiwan, in those high GDP countries that have the ability to be able to do this. But we're along there with India, Malaysia, Indonesia, for being able to control it with a lot of low-tech interventions. And for any of you who have had experience in outbreaks, pandemics, or SARS, MERS, etc., a lot of this is behavior using very low-tech interventions. So where are we with our pandemic response? I'd just like to remind you, because people get confused and they still like to China bash. And yes, I have been a WHO advisor to China. Yes, I have worked with them and reported on their response to SARS. Yes, their initial response was mixed, as it was this time. And they have, you know, like we do, 2 tiers of government, local or state, and then the federal government. And those tiers make a very big difference in how countries respond. So in early January, the Beijing ministry informed WHO and had started sharing genome sequencing on the 12th of January. Now, even had they had tens of thousands of cases in December, I'm not sure that high GDP countries like America would have responded, because I think there's an element of racism of what happens in Asia is Asia's problem, it's not our problem. So by January 22nd, they held their WHO, well, it's actually the International Health Regulation 2005 committee that decide on, with the emergency committee, decide on whether or not this is an emergency, a public health emergency of international concern, otherwise called a FEIC. Now, the independent review of WHO, led by Helen Clark and Ellen Johnson Sirleaf, quite rightly identified that there was a real problem with this binary, yes there is, no there isn't, a problem, and we shouldn't or should call a FEIC. So there really needs to be a grade so that the rest of the world will hear this. But I have to remind you that on the 22nd of January last year, every single member country would have known that an emergency committee was being held. They would have known. It did not come out of the blue when on the 11th a pandemic was called, which is basically an administrative call that says it's gone past 2 WHO administration regions. So yes, that particular committee, not Dr. Tedros, not any of the staffers, but the member countries, took 3 goes at deciding to come up with a unanimous decision. And it came up with a unanimous decision after Dr. Tedros went to China and came back and informed them. So back here, March 11, China had nearly 81,000 cases and the US had 920. So even if they had have waited for the pandemic to be called rather than the peak when they had 5, they actually could have responded faster. So there is absolutely, in my mind, no excuse about why places like the UK, the US particularly, given that they've called out China on multiple occasions, could not have, with all of their high GDP, responded. Now, the World Meter has listed how many cases per million, and I've listed it there to say that it suggests that, of course, the US still slow to act, and yet this is mixed with mixed GDP. It doesn't give you a really good understanding of what's going on. So then the Lowy have ranked countries over 36 weeks from the 100th case to, so that's about June last year for most of these countries, to January 9 this year. They looked at rolling averages for cases, deaths, cases per million, deaths per million, number of tests done, and per 1,000. And of course, our beloved neighbours, New Zealand, win, and they are ranked 1 for their response. Of course, then Vietnam, Taiwan. And so you can see it's a real mix of low GDP and high GDP, and Australia gets number 8. So it's still in a veil of why is there this mix? Why isn't America up there? America didn't get to until 94. The US is not doing, the UK isn't doing very well. But I think this particular graph says a lot. So the Lowy plotted Middle East, African countries, and Asia Pacific countries for their ranking early on. And early on, they had some cases, particularly the Asia Pacific area. They were responded with low tech interventions. And of course, then the Americas had very slow and low response, and so did Europe. But back here, down here, have a look at how they end. So how they ended was, of course, with the Middle Eastern and the Asia Pacific, the low GDP countries, coming up best with their score. The Asia Pacific score scored top at 58, and the Americas low. And of course, the Europe scored quite well, but still they're lower than Asia. So I plotted this by GDP per capita using American dollars. And what I found is that Switzerland, Ireland, US, etc., are high GDP countries, but with high numbers of cases. And we're down there with what I have labeled as appropriate response. We responded early. Now, what we did, which some of these other countries did not do, is we ignored the international health regulations of 2005, which were written after SARS 2003 outbreak, when the R0 was lower than this current SARS-CoV-2 is. And the international health regulations said, you're not allowed to close your borders. We do not approve of closing borders because it reduces trade, potentially people's livelihoods, etc., and the economy. They need to go back and revisit that, because the countries that did have done very well. Doesn't mean they need to put this in place forever, but I wonder what the global case numbers would have been like had that IHR of 2005 been removed immediately, so that Dr. Tedros, Mike Ryan, and Maria van Kerkhove would have been able to say, yes, close your borders for a short time, see how that goes. Of course, this group over here in the orange, that should have They're a great mixture of course, middle GDP. But nevertheless, it doesn't take a lot of GDP to respond with behavior compliance, physical distancing, mask use, and stay-at-home orders, which does take compliance on behalf of the citizens, and then moving up to a higher tech, which is testing and responding to testing, quarantine, which is still low tech, and then of course PCR testing, which is high tech, and potentially rapid antigen testing, which in Australia there are 11 that are TGA approved, with somewhere between 95 to 99.9% accuracy for a negative test. So they're not bad for screening people who you might expect to be negative, and have it as an augmentation of PCR testing. So I've labeled these two groups as slow to adopt low-tech public health responses. And as you can see, the Europe and the Americas, they had plenty of time to learn from the Asia Pacific regions, but sadly they didn't. And if you have a look under the Americas, that pattern is again reflected in America. Now, one can only hope that with the new president and the new authorities, they are picking up their vaccine per day. They, I think, got to 1.16 million per day. And so we may start seeing things differently, but they have had to rely on high-tech solution, i.e. the vaccine. So, to add a complication, of course, we now have the variants of concern. In the UK, they have B117. It only took 4 weeks to expand across multiple regions of the UK. The transmission has an advantage. It's somewhere between 40% and nearly 70% more infectious. Recently, a paper has come out to say the death rates may be confounded because it looks slightly higher for men, that they had a 17% death rate. It's gone up by 5 percentage points, but that might just be due to the speed at which we're seeing infections and therefore deaths. This variant has spread across 30 countries. Then, of course, we have the South African variant, and again, it's now got transmission advantage, where just in a very short time, from mid-October to the end of December, it became the variant that was circulating in South Africa. Brazil, again, they found it, first detected it in South America on March, and of course they found that it became the circulating variant at about 71% for B1133 and B1128. We haven't seen the Brazilian, but we've seen in our quarantine hotels both the variant of concern from the UK and South Africa. So how are the first 3 nations going with rolling out their vaccine? So Israel is rolling out only Pfizer. They had a very good agreement with Pfizer, paid a bit more. They provide them with lots of feedback on how it's going. They're a small country of only 9 million compared to 332 million in America and 68 million in the UK. They were able to get up to 172,000 injections per day, and they've then fallen. So you can see here, there on the left axis, and they had a decline initially at about week 4, and that was because they had a supply problem, and then they had to run 2 cohorts as well and try to organize those 2 cohorts. It then got up to 172,000 injections per day. It leveled off and they're having a problem at the moment with getting people to come forward for more vaccine. And I've got colleagues and friends in Israel, and I haven't been able to ascertain from them the reasons why. The daily injecting rate in the US is around about, and I've based this on weekly numbers, but at about 1.3 million. But recently they've got that up slightly higher. So cumulatively, Israel has vaccinated with at least one vaccine, 4.6 million Israelis. America, at least 33, nearly 34 million Americans. And the UK is dragging its heels at 1.7 million Brits. I estimated that if we were going to try to vaccinate everybody, well, I estimated it on 80% population, and from between March to October, that's 240 days, they'd be have to injecting 170 injections per day, every day for 240 days. And that included both Pfizer and AstraZeneca. So it's not an easy task, as you would know, because you're experts in vaccination. It's tricky. So I've looked at what we would need to do if we were really going to get herd immunity. Now, we don't know if we're going to get herd immunity because the evidence to date is that they've shared with us has been that it protects from severe COVID and in some cases death. So, but let's assume that it's no different than other vaccines, that we may get herd immunity. So this picture here is at the best case scenario, because I don't want to be called, you know, a drama queen. This is best case scenario at 82%. And this is based on recent data coming out of the UK, looking at delaying that second dose for 12 weeks. And they say that their efficacy is 82%. So at 82% against the wild strain, the background strain, we would have to vaccinate with just Pfizer alone. If we all got Pfizer, we'd only have to vaccinate 70% of the community. But if I'm sorry, there's a typo there. There's too many ones in the UK variant, but you know what I mean. But if the variant came in, then we'd have to vaccinate 85% of our community. Now, if we had a 40% Pfizer and a 60% AstraZeneca, we would have to vaccinate somewhere between 75% of the population and 90% of the population if some of the strains came in, and of course they go rapidly like wildfire. And if you have a look at this table, as the efficacy of AstraZeneca declines, so must our coverage must increase to somewhere between 80 and 100%. So let's just say we have a good vaccine efficacy at 82%. We may need somewhere between 160,000 to 190,000 injections per day to cover all of our population at that level. So just to sort of wrap up, what has the independent panel found? So Clark and Sirleaf found that, of course, the world was not prepared, even though they remind us in 2019 in September, watch this space, you're going to have a pandemic. And yes, they were right. A couple of months later, we did get a pandemic. So we must do better. We must use low-tech public health interventions comprehensively across the world. And this pandemic has deepened inequality. The World Health Organization was underpowered. Now, the one saving grace of the US removing itself at one stage from the WHO was it reminded all other members that they weren't paying enough for their membership, and they needed to start thinking about this because WHO has to get into 21st century. The IHR was not fit for purpose for this particular virus and its R0, and global leaders failed. And we, the people, need to start thinking about who will we have lead us for the next pandemic. And just the final thoughts, the world needs to get ready for the next pandemic because there will be a pandemic. We need to be interconnected with our fight, and we need to reset the global community to understand what a FEAC is, and this won't be our last pandemic. Thank you very much.
Mary-Louise, thank you. A wonderful talk and really highlighting, fundamental questions about us as a global community, and the fact that different countries have responded in different ways and the challenges moving forward. I'm sure there'll be lots of questions related to those different responses. Our third presenter is Professor Alan Cheng. Alan is an infectious diseases expert. He's Professor of ID at Alfred Health. He has a long-standing interest in respiratory infections and in fact set up FluCan, which is a hospital-based reporting system in Australia for influenza. More recently, Alan has been made a Deputy Chief Medical Officer in Victoria, and I know many people in the hospital community, at least, are very grateful for Alan's work, and I'm sure it hasn't been easy, Alan. But personally, I'd like to say thank you. Alan's going to talk to us about COVID-19 in Australia, and I should add, Alan's story is a little bit similar to Ben's in that this time last year, Alan was talking to us about influenza, but at very short notice actually re-gave a presentation about what was known about COVID-19 that he'd given, I think, the night before to the Chinese Medical Association of Victoria or something similar. So, Alan, thank you again for your involvement with our group.
Thanks, Lou. And I'd actually forgotten that until Ben brought back some of his old slides. So just to note, I have a number of declarations of interest at both state and federal government levels. So it is worth thinking about some of the advantages and disadvantages that Australia has. So obviously we're a pretty wealthy country at the far side of the world with a good public health or public health care system, perhaps maybe not quite so strong public health system. But that wasn't enough to stop us getting some early cases in travellers from the end of January. And in fact, two Australian cities are among the top 20 destinations for Chinese travellers. We also don't have a CDC, one of the only developed countries in the world that doesn't have one. And in fact, many times we do act like 8 different public health systems, with being a federation of states and territories. And then we're also not immune to all the other developments happening elsewhere in the world with casualised workforce and other economic forces. So it's very difficult to explain Australian public health governance to anyone overseas. In fact, it's pretty hard to explain it to Australians, really. In the absence of having a CDC, what we do have is this AHPPC, which is a committee of chief health officers and a few other invited experts and other representative organisations. And then in turn, they are informed by technical committees under them. So the Public Health Laboratory Network and the Communicable Diseases Network of Australia, which comprises the state communicable diseases leads. So very early on, we had declared a national incident response and developed a national COVID response plan. Looking back on that now, it seems rather quaint, but it did get developed and it was put out relatively early. And we had our first wave, and you can see here that the borders to China were closed relatively early and a little bit later to other countries as the pandemic spread around the world. And then finally, towards the middle of March, the borders were closed completely. And actually, despite all the other things that you see there, this probably was the factor that that slowed down the first surge of cases, and then the other things that were done really stopped it spreading on from return travellers. But quite early, we did, we did note that some of the jurisdictions were starting to do things independently, and this was really the first cracks in the national approach to COVID. And actually, this is quite reminiscent of what happened in 1919. In the Spanish flu, where the borders were closed unilaterally by different states and territories. And this is quarantine tents at Albury when the Victorian-New South Wales border was closed. So perhaps we might have also learned about tents, but I don't think that really is possible in this day and age. So things had been going okay. We in Victoria we had an issue with a cluster at Cedar Meats in sort of towards the beginning to middle of May. And then in June was really when we started getting a resurgence of cases coming out of our quarantine hotels. And you can see here that the yellow dots are those that have come from overseas, the black dots are those that are thought to be more locally acquired. And you can see even the source of the cases for the Ridges Hotel and the Stanford Hotel outbreaks there. And so we had sort of hotspots spreading through different areas. And there was a response to try and limit these, but these were really had probably gotten loose before we were able to impose lockdowns to prevent them. And this really was the source of the second wave that came through July and August, and then finally came under control in September and October. We really saw outbreaks through all of really the settings that a lot of other countries have seen. So aged care was hit very hard to a lesser extent, but importantly, disability residential facilities. We had outbreaks in hospitals, those associated with schools, perhaps not so much transmitted at schools, and then many high-risk work sites, meat and food processing, cold storage and distribution. And these really affected very specific populations. So particularly aged care and meat and food processing, have a lot of workers that from culturally and linguistically diverse backgrounds. A lot of these people would have been what we would call essential workers, and actually Victorian data suggests that about in our stage 4 lockdown, where we were specifying very specific industries, about 25% of the workforce actually fall into this category of essential workers. And then people in crowded housing, so public housing was an important setting, less so, but importantly international students, and then large households. So we learned a few things through this. So firstly was the importance of community engagement. There are many, many different community groups, and they're variously defined, not just by the language they speak or their ethnic group. And it was a lesson that we learned a number of times to really try and avoid stigmatizing any particular group. Obviously, the Chinese popped it fairly early, but even later on, various different ethnic groups had the finger pointed at them unintentionally or in other senses. And some of these groups are quite heterogeneous. So particularly if you think of the Chinese community, people that are probably more like me, born in Australia, and my parents that have been here for a long time, the way to communicate with them is clearly very different to international students from China or others that might be doing different sorts of work. There was a marked difference between some of the more established older communities, so Greeks, Italians, Chinese, and then some of the more the newer communities that may not have had such strong links to health. And so some of the responses to this were through the local public health units for example, Monash Health had a lot of pre-existing links to some of these families through their refugee health services, and really reinforced some of the importance of primary care in the response. The second really was that a lot of vulnerable settings really needed a very rapid response, and it'd be fair to say that residential aged care facilities are not places that are used to having to have an emergency management response. I guess you know, they have fire and other responses, but you know, a complex outbreak like of complex emergency like an outbreak is somewhat unusual for residential aged care, and particularly that the first thing you often do in these outbreaks is to send everyone home because they're close contacts. And even things like, you know, who takes out the waste and who's going to do the cleaning became very difficult problems. And then high-risk workplaces also presented a number of challenges. I remember having issues with, you know, how do we clean our freezers and disinfect freezers, because all the fluids that you usually use to clean things freeze, you know, at -20. Anyone who's studied any public health 101 is about the social determinants of health, and we really had this lesson played out many times. So essential industries are often poorly protected, and thinking particularly of meat workers. So if you think of why people didn't isolate, it might be that you know, they didn't know about it. Obviously towards the end that was a bit less likely, that they wouldn't do it or that they couldn't do it, and that was an important lesson that we have. So things like pandemic leave and JobKeeper from the Commonwealth were obviously important there. That public health interventions do need to be very quick. We imposed our stage 4 lockdown. You can see that, you know, if that had been brought forward a little earlier, perhaps things, you know, might have needed to go on for so long. But obviously it's very difficult to know in the heat of the moment what is actually going to work and what doesn't. You can see really here that we really needed stage 4 restrictions to get things down, the effective down below 1 in this case. And just noting that, you know, what might have happened in Australia otherwise is we had very similar numbers of cases towards the end of July as the UK and France, but obviously the trajectory since was very different. And then the final thing really was about scaling responses. It's very difficult for ordinary people to think in an exponential frame of reference. So one of the things that we were told early from China is if you know, we think when things are you know, they're increasing exponentially, what it really means is that if you have 1 ward of patients this week, then next week you might have 2 wards and 4 wards and 8 wards and so on. And that's a very difficult frame of reference to think of, and also in terms of the surge workforce required to look after that. So a lot of these issues, you know, we've learned, I guess, the hard way in Victoria about trying to respond to some of these issues and to improve our responses. And if you really look at the responses late in October and now even more recently, they're very different to the responses in June and July. There have been a lot of improvements in contact tracing, really trying to focus on high-risk settings, to focus on case investigation, and actually to try and measure a lot of these things to make sure that we're improving the efficiency of notifications and their processes. So in terms of the future, there's obviously a lot of work being done into different testing strategies, and I think there's a talk tomorrow about you know, all the different technologies that are going in there. But a part of it is about not only the testing technology, but how to implement that in high-risk populations and getting testing out to people that need it. Hotel quarantine is a continuing challenge, and noting that a lot of people in hotel quarantine do need non-COVID medical care, which does pose challenges for example, if you wanted to put a hotel quarantine facility a long way from Melbourne. And then finally thinking about surge capacity. And then haven't really mentioned it much, but the COVID immunisation program, which Ben and Mary-Lou have mentioned. And just as an example, with hotel quarantine, these are some of the measures that have been put into place to try and strengthen the hotel quarantine system, thinking about particularly governance, to have one responsible agency that's oversighting the whole process, making sure that every staff member that works, and there are, I think, something like 8,000 or 10,000 people working in hotel quarantine, making sure they all have education and training, and there's auditing to make sure that they're doing the right things, and then thinking about workflows and engineering and other protections. I thought I'd just finish by sort of talking about some of the personal reflections about being involved in the response. And I think some of the media advisors very kindly said that after a month, I didn't quite look like a deer caught in their headlights anymore at a media conference. But you do know that when politicians are becoming sympathetic to your plight, that you're probably struggling a little, and it's certainly using a lot of skill sets that I wasn't really very familiar with. And I think it wasn't really any surprise to get a lot of criticism, particularly from politicians. But when particularly as we were trying to ease off, or thinking about easing off on restrictions and the timing of those, we certainly got a lot of criticism from all quarters. And I did wonder at one stage whether this was close to be a career-ending event. But thankfully, things have worked out reasonably well. But thankfully, things are not as bad as they could have been for, when we think of other academics that have been put into, decision-making positions. So I'll finish there with a lot of thanks to quite a lot of people back home at Alfred Health and Monash University, but also among the infectious diseases community and in the Department of Health.
Alan, terrific, thank you. And again, there are lots of questions, and I'm sure that they're going to be asked. And so we've got time now for a vigorous panel discussion. So Alan, Ben and Mary-Louise. And there's a question that Damien Purcell has asked, and a number of people have actually sort of also wanted answered. And it's really asking, is there a biological reason why things might be different in some countries than others? But there might be other reasons apart from biology. So would anyone like to answer, could the impact of community immune memory from exposure to previous non-pathogenic coronaviruses be affecting what's happening in Southeast Asian countries, essentially? And just as I'll add a second, or is it, having been through a SARS crisis several years earlier, does that scare the living daylights out of some countries? And then I also
Ben, Ben, can I just mention, as a non-resident of Hong Kong, because Ben is a resident, as a non-resident, and I was very lucky to review the response of SARS in Beijing and the response to SARS in the Hong Kong SARS designated hospital. That remained confidential because it was getting ready for the Legislative Council. But what my observation was that they took it very seriously. They responded very rapidly. And certainly once China spoke to WHO, they responded rapidly. The report that I did with Beijing Health Bureau identified that 10 really important days were missed. Ring fencing was missed. And I think that Professor Liang using ring fencing in Wuhan is a great lesson learned. That's brilliant. And looking at how healthcare workers and the public responded in Hong Kong as an outsider. Now, I used to go to Hong Kong 3 times a year to work. Sadly, I haven't, and I miss the country very much. But my understanding and observation, Ben, correct me, but I thought that they all took it very, 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 very seriously, and they responded with a behavior. So I was really interested, Ben, at your figures about how they're getting fatigued, because SARS went for until June, when they called it off. So that surprises me that they're getting fatigued, but it has been twice as long.
Yeah, exactly. So I think there was a lot of investment in Hong Kong after SARS in 2003 as a result of that report. So the government invested in isolation rooms in hospitals, 1,400 negative pressure isolation rooms for our population of 7.5 million. If you scale up to Australia, you can work out how many that would correspond to. I think that's probably one of the highest in the world. And those have been used for COVID. Infection control in hospitals. So as I said, in our cohort, 800 healthcare workers, only one with evidence of infection. And you compare that with what we've seen in Europe and the US with enormous numbers of healthcare worker infections because of lack of preparedness, lack of training, lack of PPE, lack of infrastructure for infection control. And then the community's done very well here as well. I think the SARS experience means people knew what to do. They wore masks, they did stay at home, but now people are getting tired. And I think that's going to play into vaccine hesitancy as well, where we haven't suffered as much as in Europe and the US. We've just seen it on TV. So people here are asking, why do they need to get vaccinated when no one they know has got serious COVID? They haven't, they don't think it's a problem. We've done okay in the past year. We'll just be okay in the future without realizing that we would like to go back to normal. We'd like to open the airport and trade and so on. And we can't do that at the moment.
Can I also say that the other thing that Hong Kong did during SARS was to start getting a dossier of every healthcare worker that worked in the SARS designated hospital, so that they knew if you were an ICU trained in infectious diseases. So if they ever had another one of these outbreaks, they knew who to call. And they also used healthcare workers who were not of great use initially, clinically, such as obstetricians, some surgeons, to actually ring up family members, the clinicians' family members, to say, so-and-so is, Wing Hong is fine, and he sends his wishes, or he wants you to do X, Y, Z. And there was a real connect, because sometimes where they were all their PPE, they couldn't talk to their families as rapidly. In 2003, mobile phones were not around. So they tried really hard to help that mental health issue as well. Mind you, though, Hong Kong did have a real struggle, but at least everybody suffered PTSD afterwards. But yeah, I think they've learned a lot from SARS.
Yes,
so are we saying that there isn't a biological response, so that's a sociological one?
Yeah, I was going to go back to the question to say that I think that there's probably enough other factors that probably explain the differences between different countries than having to invoke biology. But obviously, it's a very interesting question about HLA types and other things as well. But I don't think at this stage, at least, there's enough to say that there is. And also noting that other countries did get SARS cases, so famously Canada, and haven't done quite so well.
So if previous experience with SARS might be one of the triggers, well, what about a country like Rwanda that does so well on the Lowry Institute table? Is that related to Ebola, or is that related to just the catastrophic genocide that occurred a number of years before and enhances social cohesion?
I'm not sure. I'm not an expert on Rwanda, but I do understand that they have quite a good healthcare system and possibly quite a good public health system. But, I think
they've got a very good surveillance system going on. That really certainly helps. And back to Canada, without disrespect to Canada, they refused to close their border initially until they started to get infections when they had an outbreak from a church meeting. So they came to the party late with SARS, and maybe they've learnt from that nasty experience.
All right. The next, I think, tricky question is from Rod Pierce. Hotel quarantine. What's the best model, and where? In the centre of Gotham City, or should it be out in the desert somewhere?
I'd actually be interested in how they do it in Hong Kong. Obviously, there's no desert, no remote desert in Hong Kong, but and I'm sure that it's not perfect there either. But I'm just interested in what the setup looks like. And
Yeah, sure. So it's evolved actually. Going back to March, we had a system of home quarantine with a wristband with a GPS monitor, where the first thing you did when you got home as a quarantinee was to walk around the extent of your home so it could track what's the limit of your residence. And then from then on, you couldn't leave. But it didn't work that well because obviously there's other family members living with you who are not subject to the quarantine. So it changed to hotel quarantine, probably July or August. And initially, hotels were dual use. So they had regular guests and they had quarantine guests on, sometimes even on the same floors, sometimes on separated floors. And that meant that visitors were able to get into the rooms of people who were in home quarantine. So again, an opportunity for leakage. And there's a suspicion that our third wave in Hong Kong actually began because of a lady visiting her son who'd come back from the UK who was in hotel quarantine. So now it's extremely strict. Hotels are single use only. They are either bought out by the government to be used for hotel quarantine, or they are just for other people, not for quarantine. It's one or the other. And it's a very strict 21-day quarantine now. So from the airport, you're taken to the hotel and you're sent to your room and you stay in the room for 21 days. Not like New Zealand, where you get an hour outdoors every day, or like a prison. In Hong Kong, there's no outdoor time, no fresh air. It's just 21 days in a room. And it's tough. It must be really tough for some people. I'd really hate it. So now, and then you can order food delivery. The hotel staff will leave food for you or gifts for you outside the room. There's no contact between the hotel staff and the quarantinees. It's just left outside the room, knock on the door, and no face-to-face contact. So very, very strictly controlled. And with an extension from 14 to 21 days, there have been a couple of late cases picked up with longer incubation periods. We know it's possible. We don't know if those cases are the contagious type. I suspect they may not be very contagious. So I suspect the extension from 14 to 21 days doesn't make much difference, but I don't know. It's an interesting kind of question. So yeah, and I guess that's going to be in place for at least another 6 months, if not another year here in Hong Kong. I'm worried, as Mary-Louise's calculations showed, I'm worried that if we use too much of some vaccines, if we use too much of a vaccine that's not the Pfizer vaccine, we may not reach a level of immunity in the population that allows us to stop the quarantine for travelers. So that would really be a concern, I think, here in Hong Kong.
Yeah,
exactly, Ben. I'm really concerned that the authorities are very busy trying to get Australians to get on board with vaccination, and your numbers don't surprise me, because there's a really old-fashioned but really tried and true approach that says a third of people are early adopters, the second third are late ones, but they come on board, and then there's the laggards that you just can't get on board unless you fine them or something for not wearing a seatbelt. So we've been concerned about that, but we haven't started really talking about the proportion of people that will be, even with a mix of vaccines, with the Pfizer and the AstraZeneca, even at 80-odd% efficacy, if it does work like that, what we're going to do about those that don't even know that they're not protected. And then about the 55-year-olds and over, because AstraZeneca had very small numbers of samples.
Yeah, it's interesting to think about hotel quarantine models. And just to give you sort of an insight to how in Victoria, so we have, I can't remember, I think about 2,000 beds. So, at an average of 14 to 14 days, 14 days of quarantine, that's, only a couple of hundred people coming in each day. And, about 10% of people actually need some sort of medical care. Only 1% get COVID, obviously, but a lot of people need mental health care, and there's enormous staff that need. A lot of them come to hospital. At the Alfred Hospital, where where most of the people with physical problems go, and then there's a number of hospitals that take mental health issues, but they're very challenging. To deal with, and then with all the overlay of the infection prevention that's required, it becomes more difficult. There are something like 10,000 staff that are involved in this, and to have we now have exclusivity where, you can't work anywhere else. In Victoria, you can't go back to the hospital. There are more people working at the hotels than there are at the Alfred Hospital. So, that's a really difficult, challenging problem for us. So to put facilities out, so even Howard Springs obviously is another example, which is the facility near Darwin, but with any sort of medical issue, they often transfer them out to their home state to have their medical care. So that's not really the perfect model either. So we are struggling with what is the perfect model, and I suspect that what it is actually to have multiple layers of protections, pre-contact tracing or contact mapping, this daily testing, trying to get onto any cases that might occur in staff early, but it is a continuing challenge.
Well, one of the problems, Lou, if I can just add to that, one of the problems is, Ben, that we are, states and territories, and each state and territory is allowed to do their own health system, and of course that's the government, but they also are taking care of quarantine programs, and they have slightly different approaches. I mean, even one hotel that I've been told about still has a restaurant for the community to go into. Now, sure, it's a different exit and entrance, but from those that are travelers. But as a catastrophizer, when you do plan for outbreaks, you have to catastrophize and not just think infection control. And that's where you really do need behaviorists and security experts who have worked in war-torn countries for all sorts of things. So I'm hoping that as a region and as somebody that works with WHO, they'd love a regional approach to best practice.
So Alison Martin has really touched on this in her question as well. You have this concept of a state versus a federal, and Alan sort of highlighted it when he talked about our lack of a CDC. So what would be, what is needed for this to become a federal unified response, and what would be the first steps?
Well, I think, public health is a state responsibility. So, we have a constitution that spells out, what is the responsibility of the federal government. Quarantine is one of those. Borders, foreign policy, and taxing people. So all the money goes federally. But public health and hospital services are a state responsibility. If this was to be more uniform, the system would be some sort of federal state agreement. So as an example, drug regulation was devolved from the states to a federal agency to do that. There's clearly no benefit in each state having its own drug regulation. So yeah, it's difficult in the heat of things to see what the model could be, but clearly all the public health workforce is really in the states. And to be fair, having local responses, local public health units, local people that know their communities does bring some benefits. And I think having competition between states, isn't always great, but it does, when one state is doing things better, the others can learn from it. So I'm a bit on the fence about how much needs to be federal and how much does need to be at the jurisdictional level. I'm sure Mary would have
Can I be the fly in the ointment here?
Yeah, sure.
I think the competition is really between us humans, we humans, particularly not just Australia, but in the Wipro area, and against the virus. And we collectively need to come together to learn to make best practice. And I actually think that states and territories could I agree that local response is perfect because you understand locally what's going on, but there needs to be a national best practice and then share that with places like Hong Kong, Beijing. They've got expertise that is, out of this world. So we could be sharing and then picking up the phone and saying, we've tried this, but it was a clanger, it didn't work. And so from my perspective, the virus, we need to be competitive against the virus and collective nationally and regionally.
Mary-Louise, thank you. Although I'm putting my money on the virus, it seems to exploit the weaknesses of human nature. There's an interesting question from Stephen Tong about the proportionality of a response, in terms of lockdown and so on. And so, if all three of you could give your view, is it for the greater good? And as a hospital clinician, we were terrified that we were going to be overwhelmed during one of the waves. And Ben, I think I agree with your comment about the terminology wave, but at least when it becomes being overwhelmed, the wave does make sense, and flattening the wave sort of makes sense. And I know people in hospitals have been very grateful for the sacrifices that the general community have made so that the public hospital system hasn't become overwhelmed. But do you have views on the proportionality of the response?
I can start. So, Ben, do you want to start? No, Ben,
no,
you go.
No, go.
No, look, as an epidemiologist, and of course, I'm in health and outbreak management and hospital infection. I only see action for the greater good. You put away your personal needs for the greater good when you're talking about a pandemic that has killed over 2 million people, and you don't know how many people it's going to kill initially. So if you respond rapidly, you're more likely globally to be able to get back closer to normal than trying to balance the economy with a response. So from an outbreak management perspective, epidemiologist, I believe that you go in hard, and there's a mantra. And of course, I think Jacinta Ardern's advisor has been an outbreak manager. Go in hard, go in early to get out early.
Yeah, I would agree with that. And the only thing I would add is going in hard doesn't necessarily mean going in with everything. It means going in with the best mix of measures that are most cost effective in getting the numbers down to a low level, but maybe short of everybody staying at home for 2 weeks or a month, which is what was done in China, as well as going door to door, testing everybody and isolating and quarantining. So I think we've seen it in the mainland is probably the most extreme response. And still, even now, when there are cases in cities, they'll do a total lockdown, everybody stay at home and everybody gets tested. I mean, it's extremely expensive, but it does get the cases down very, very quickly down to zero, and then things can get back to normal. I'm still wondering, is it necessary to be that aggressive, or can you still achieve the same aims with a little bit less? With what's the right mix of measures? But I totally agree. If the quicker you get the numbers down to zero, the quicker you can get back to normal, and that's going to be a lesser impact on the economy in the long term and society.
So, Alan, sledgehammer or tack hammer?
Yeah, look, I mean, I agree. Proportionality is, Victoria has a Charter of Human Rights, one of the few jurisdictions in Australia that does have one, and everything we do absolutely has to be run through the Charter of Human Rights to say, is this proportionate to the restrictions that are going to be imposed? And I think for us, the equation was really, the tighter the restrictions from, when we were reaching our peak, the shorter the time that they would have to be imposed. So everything that we did to say, you're allowed to do this, or this might be an exception, or that, and obviously there were exceptions, they're essential work and people still need to be fed. There was a huge flood of people saying, well, what about this industry? What about that industry? And everything that we would have loosened would have just made it, go on for longer. So I did think that we probably did, the tightest that we possibly could. And that meant that it was about the shortest it could. I am, always continually mystified by this sort of economy versus the, health debate that kept going on. Clearly, the shorter that you know, it's the best way I could describe it is like that. You know, they talk about that marshmallow test for kids, where you know you tell the kid that if you eat your marshmallow now, then you won't get any more. But if you come back in 10 minutes and you haven't eaten it, I'll give you two. You know, this is almost like a marshmallow test for countries, where you know you defer being able to have more freedoms by you know a short-term pain.
Yep. And it requires leadership to achieve that speed, doesn't it?
Yeah, and you know, it requires sort of that message coming over, but also, you know, obviously politicians who are, you know, expert at communicating to accept that message and to sell it, and obviously that's more difficult in some countries than others.
There's a question from John Litt about whether we know enough about the effectiveness of the AZ vaccine in elderly people to be rolling it out to them.
I might take that one.
There's a lot of questions about vaccines. Yeah, go on, Alan. Go on,
okay.
Alan.
So
I've got questions as well.
Yeah. So it is difficult. So clearly, there's not a lot of there weren't a lot of people involved in the AstraZeneca trials to date that were elderly. So I think it's 660 or over 65 or something like that. So there isn't a lot of data. The TGA are still looking at you know, any conditions of registration of the AstraZeneca vaccine. Having said that, there is the US trial, which I understand has about a quarter of their participants are over, I think it's 65 or 55, where there should be data, and that is due to report fairly soon. So we're hoping that there will be good data in the near future. Ben, I don't know if you want to add to that.
You know, I'd also ask about the other vaccines and whether they can protect against mild disease, because I think the numbers we've seen are not necessarily comparable. We've seen 95% for Pfizer, 90% for Moderna, but the outcomes in those trials were moderate or severe illness, not so much mild or asymptomatic illness. And so that when you compare with the numbers for AstraZeneca that have been a bit lower, I'm not sure they're completely comparable. And I wish there were just more data on all the vaccines, on how effective they are against different severities and in different age groups, and the more information, the better.
What do you think the best way to study that is, Ben? Because you know, if someone has asymptomatic infection, they have a heap of antibodies around, you know, they may actually not be infectious at all, even with mild infection.
Yeah. No, I understand. There's some studies are being planned right now to look at the degree to which some of these vaccines can reduce transmission, but it's difficult. And in the phase 3 trials that the interim analyses have been published, and now there's a big debate about whether the placebo recipients should be given the vaccine as a priority because they were kind enough to participate in the trial. And if that happens, then we won't get any more data on the durability of the vaccine effectiveness. So it's, you know, there's this big rush to get the vaccines out into the community, and we do need the vaccines, but we're missing the chance to collect more data on exactly how well they're going to work. And if they don't work as well as we're hoping, we're going to have more trouble in the coming year, unfortunately, more trouble with COVID.
At WHO, we had an update with the vaccine group updating and the epidemiology group updating, the infection control epidemiology group. And we were all asked what we thought about breaking protocol, and all the epidemiologists and the vaccinologists all said no. I don't know, Ben, you might have been at that meeting too, and they all said no, the protocol shouldn't be broken because there's so many things we don't know yet, and particularly about transmission.
Thank you. We've probably got time for one last question, and there's quite an interesting one from Richard Clark about whether the emergence of highly infectious variants is evidence of a breakdown in public health leadership, because they seem to be occurring in countries of high prevalence. And I might just add in, what would happen if the virus started infecting children? Would we, severely? How would the world respond differently? And I keep thinking of the Pied Piper of Hamelin.
I mean, I probably can sort of start perhaps. I mean, I think that it probably has emerged in some countries because they have a lot of virus. So there's a lot of viral replication, and therefore there's the potential for variants to emerge, as opposed to places where there's no virus and not, things aren't going to emerge except from other countries. But that's probably the only main link I can think. I would be interested in Ben and Mary-Lou's opinion about how the degree to which these variants are more infectious and perhaps might cause more severe disease, because there's a lot of discussion about that.
I'll just add to that about more circulation, the more you're putting the virus under pressure. And there has been a small talk about that perhaps, it increases the probability of this virus circulating with people who had an immune deficiency, and it allowed it to select itself. We saw a very similar thing happen in Hong Kong during SARS with, remember Case YY from the Amoy Garden? He, was hemodialysis patient, and that changed the virus somewhat, where it became more diarrheal than respiratory. So I haven't seen a lot of studies on that, just a lot of chat. But over to you, Ben.
No, there's pretty good evidence now that these variants are more transmissible, and some of them are also causing more severe infection. What we haven't yet seen are variants that escape vaccine protection. There's some suggestion that some of these, maybe the vaccines are not quite as effective on these variants as they are on the previously circulating strains, but still they have an effect. What I'm going to be worried about is in the next 6 or 9 months, if real escape variants emerge. Now, some of the vaccines can be updated to deal with those variants. The mRNA vaccines can be updated pretty quickly. And maybe we're going to face the need to have booster jabs in a year's time. But it's a real concern, especially in places that are vaccinating when they have a lot of virus in their community. That's a lot of opportunity for vaccine escape to emerge, a lot of opportunity. So it's a real concern.
Ben, thank you. I'd like to bring this session to a close. This is where we would normally in the past sit down and have something to eat and a glass of wine. We are due to come back at 8:30. 3 terrific presentations and have really set the scene. Thank you. Do come back at 8:30. We've got a special surprise for everyone. Our man in Wuhan is going to join the panel discussion at the end of the next session. So please rejoin us at 8:30, and thanks again to the panel.
Thank you. It's been a great pleasure.